There's a wide variety of new mutations that could potentially impact on our therapeutic course for patients with adenocarcinoma. If you think about that pie chart that is often shown for adenocarcinoma, that breaks the patients up into categories based on whether they're KRAS mutation, EGFR mutation, we are going to be adding significantly to that pie chart. However, the slices that we are going to be adding to that can be very thin. So for instance, just to give one example, NTRK1 mutations are very actionable. However, they may represent significantly less than 1% of the population. So in terms of the future of mutation testing, what we need to do is next generation sequencing multiplex type tests that pick up these rare mutations. There's absolutely no purpose to be screening patients individually for an NTRK1 mutation if the odds are going to be 1 in 100 or even 1 in 1,000 that they have it. However, if you are performing a wide panel that can pick up these mutations, then you will come across these potential mutations that can benefit a lot from modern therapies. Other potential mutations that could be of benefit include the FGF3 fusions and a number of signal transduction mutations that can impact on combinations of therapies that we can consider. So in my mind, the future of mutation testing is to take a very wide look at a number of different mutations, even if they represent very rare mutations, as long as they're actionable. We owe it to our patients to try and identify them so that they can receive a targeted therapy. Additionally, I think what we'll start to see in the future is the ability using liquid biopsies to track patients over time. So a patient will start on a course of therapy, and as that patient goes through their course, we can actually perform liquid biopsies at regular intervals. And this will allow us to look for any changes in the tumor biology that might impact on the activity of that therapy. And then we can intercede, potentially at an earlier stage. So one can envision a time in the future where we're using liquid biopsies to look for changes in the tumor biology that will allow us to adjust our therapy accordingly to keep those patients in a state of tumor control. There is no cure right now for metastatic lung cancer. So the goal is to see if we can put patients in a state where we can keep their tumor growth under control for long periods, hopefully with good quality of life. And to do that, liquid biopsy approaches and molecular biology in a serial fashion can enable this. Technological advancements for mutation detecting in lung cancer really are looking at two different parameters. First of all, sensitivity. How small a percentage of an allele can we detect, for instance, in a liquid biopsy, and still is relevant to the treatment course. In some cases, tumors shed such a small amount of circulating tumor DNA into peripheral circulation that we may be running into stoichiometric issues with a tube of blood. There may only be 1 or 2 copies or 0 copies in a single tube of blood for that particular marker, which makes it very interesting to try and detect something that is that rare. Alternative to that, we are looking at a wider range of mutations, not just the primary mutations that we know about, EGFR, ALK, etc., that we have therapeutics towards, but we should be looking at companion mutations to those markers that can influence the activity of our best drugs. So for instance, only about 75% of patients actually benefit from an EGFR inhibitor, even though they have an EGFR mutation. What are the additional factors that are involved in whether that patient is going to benefit or how durable the benefit will be? And we're beginning to isolate different factors that can give us a lot of insight into this. And it gives us the potential to be able to prescribe additional therapeutics on top of an EGFR inhibitor that might be of benefit. And that will be a real breakthrough. Again, the ultimate goal is to see if we can keep tumor growth under control for long periods of time.